Hello, everyone, and welcome to our 2024 PKD Summit. My name is Michelle Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization that's solely dedicated to fighting PKD through research, education, advocacy, support, and awareness. This session is a roundtable discussion with nephrologist Lisa Guay-Woodford and ARPKD patient Marie-Pierre Schryburt. We can take questions throughout the roundtable discussion if you'd like to put questions in the Q&A area or in the chat. This session is being recorded and will be available to view on our YouTube channel in the coming weeks. So I'll now introduce our panelists. Dr. Lisa M. Guay-Woodford is an internationally recognized pediatric nephrologist whose work focuses on identifying clinical and genetic factors involved in the pathogenesis of inherited renal disorders, most notably autosomal recessive polycystic kidney disease, or ARPKD. Her laboratory participated in the identification of the human ARPKD gene as part of an international consortium, and her group was the first to identify a candidate modifier gene for ARPKD. She has directed the NIDDK-funded Hepato-Renal Fibrocystic Disease Research and Translational Core Center, initially established when she was at the University of Alabama at Birmingham, UAB, and she continues to serve as the co-director of the UAB Childhood Cystic Kidney Disease Core Center. Her research program has been funded by NIH, the Burroughs Wellcome Fund Clinical Scientist Award in Translational Research, and Polycystic Kidney Disease Foundation in the US. In 2009, Dr. Guay-Woodford was awarded the Lillian Kaplan International Prize for Advancement in the Understanding of Polycystic Kidney Disease, given by the PKD Foundation in the US and the International Society of Nephrology. Dr. Guay-Woodford has assumed the role of Senior Advisor for the Clinical and Translational Research Initiatives and Director of the Inherited Kidney Diseases Program at the Children's Hospital of Philadelphia, CHOP. She holds the Presidential Scholar Endowed Chair for Clinical and Translational Science and serves as Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. And our patient perspective today is provided by Marie-Pierre Schryburt, and she is an ARPKD patient who has received a kidney transplant shortly after her transition from pediatric to adult care. So welcome to both of you, Dr. Guay-Woodford and Marie-Pierre. I thought I would begin the roundtable discussion with an introduction to PKD in children. So I'll direct some of these first questions to Dr. Guay-Woodford. Are there any differences between PKD, whether it's ARPKD or ADPKD, or are they both the same?
So there are certainly differences in the two forms, the recessive form and the dominant form of PKD, but it's an important question because there also are points of overlap. And the overlap, I think, is most remarkable and notable in the newborn period. So children who are born with what turns out to be the dominant form of PKD, classic family history, defects in the key genes that are involved in ADPKD, can look for all the world like children who have ARPKD. In other words, they can have very big kidneys, have problems with high blood pressure, et cetera, et cetera. Similarly, children with ARPKD, while 2/3 of them present in the newborn period, there's a long tail of presentations. And some of these children come to medical attention later in childhood or even in early adulthood. And so that later presentation could make people be thinking about the dominant form of the disease. I think that really when we think about childhood PKD, we have to be mindful that there is this overlap. But in general, there are kidney issues that are involved in the dominant form of the disease that have some similarities to ARPKD, so hypertension, and we worry about kidney function, we worry about concentrating ability. But there also are differences there. So children with ADPKD can have significant issues with pain, with cyst rupture. Those are not typically problems that children with ARPKD.
Thanks so much. The next thing I wanted to ask was, what are some of the common symptoms and challenges for either type of children diagnosed with PKD?
So again, because there is this sort of spectrum of presentations, let's pick the prototypic child with ADPKD, okay? So this is a child that doesn't present in the newborn period and may come to medical attention because their pediatrician notices protein in their urine or blood in their urine, notices that their blood pressure is elevated compared to what are the standard blood pressure values for a child that age. And very often those observations are informed by the pediatrician knowing that there is a family history of dominant polycystic kidney disease. Whereas children with ARPKD, as I mentioned, 2/3 of them present in the newborn period. They can present at an older age, and the course of these children is that the younger children, their clinical issues are dominated by their kidney-related issues, high blood pressure being a very, very common feature of children with ARPKD. Issues about kidney function, issues about them being able to concentrate their urine. So for little children, having fever, having a vomiting or a diarrheal illness where there's water loss, you have to keep really close attention to that because they can't concentrate their urine. And I think that those are sort of some of the major higher order manifestations of these two groups of children.
Thanks. Repair, do you want to weigh in a little bit? Do you remember, have you known your entire life that you had ARPKD? And if so, what are some of your early memories of what might have been different between you growing up and just a typical child?
Yeah, so I think, and like I could be wrong here, but I'm pretty sure my mom found out that I had ARPKD when she was 17 weeks pregnant. So I was well into the newborn stage. I also have an older brother that has this also ARPKD. So when it wasn't anything different in my house, because I had a brother that took medication that went with me to my appointment. So for me, it was normal. And it wasn't until school when, like I wasn't in gym class because I wasn't allowed. And like, that's when I was like, oh, there's something different, and, when you're 4 and you go to your appointments, you have no idea of really why you're there, you're just kind of following along with your parents. But, I had people come and take me when I was 3 years old before nap time to take high blood pressure medication. So like I knew something was going on, but it wasn't until like middle school that I really wanted to start getting into it and truly understood what it was.
And if you don't mind my asking, and at any point, feel free to share or not share, whatever you feel comfortable with. Do you remember things like hospitalizations or, periods of not feeling well for various reasons when you were young?
Yeah, I think I've definitely had periods of hospitalization. I think one of the main tests that we kind of did a lot as children were scopes. And like those who would have to go in, spend the day at the hospital, we would go under, and then we would, and that was kind of like a big deal. And then definitely like later on, I would get hospitalized if I was like sick and like I didn't have, the immune system to beat whatever I had. And so I would get sick a lot easier. But yeah, I think it kind of just depends.
Thanks so much. Moving along in the disease progression, Dr. Guay-Woodford, what's a typical progression of PKD in children, and for either type, for ADPKD or ARPKD, and what should parents of a child with PKD expect as their child grows?
So for the recessive form of polycystic kidney disease, let's say the child that has the classic presentation in the newborn period, the issues that are sort of on the immediate horizon are issues related to their kidneys. So it's the kidney size, it's blood pressure, sometimes it's kidney function. And then as the child grows, then many of these children, not all, but many of these children have issues related to the liver lesion that at least under the microscope, is always seen in ARPKD. And to variable extents, there are clinical consequences of this liver lesion, and that liver lesion is called congenital hepatic fibrosis. And so sometime around the time a child who doesn't, have any sort of known issues with their liver should probably have some sort of baseline screening to establish what's going on. And that screening, depending on your healthcare system, may even involve an initial baseline evaluation with a liver doctor, a hepatologist. But as children grow, as children with ARPKD grow, it's really the kidney is the predominant issue early on, and then the liver sort of becomes, for many children, an issue. And so by the time that they are truly school age, there are children who are dealing with issues related to the kidney and perhaps also the liver. In contrast, most children with ADPKD present at a later age. And I'm talking about children who come to medical attention because they have an identified issue. They either have blood in their urine or protein in their urine. They have high blood pressure. Less typically, they've had a urinary tract infection, and that prompts a diagnosis. For those children, again, the most pressing clinical issues relate to their kidney. These children can also have high blood pressure. But because the nature of the cystic formation, as I've talked to this group about in the past, is different. ADPKD is characterized by soap bubble-like cysts, and these soap bubbles can rupture. So kids with ADPKD may have normal blood pressure, they may have normal kidney function, and their issues may actually be related to pain, either because of the size of their kidneys or acute pain because these soap bubble-like cysts can rupture.
Great. Are there specific milestones or red flags in the kidney function or in when the child is being tested and monitored that parents should be watching out for as their child grows?
Right. So many parents and patients that come to see me, this is obviously a very frightening, set of disorders. And because there is so much information available on the internet, they have done their research. They have looked at Google. And while the web can be very informative, it can also be terrifying. And so they'll read stories about, loss of kidney function, having to go on to require what we call renal replacement therapy, be it dialysis or transplantation. And the sense of timing is something that they don't necessarily have. And so there's a fear of, could I wake up on a Thursday and my child have significant decrease in kidney function? In other words, can these things happen abruptly and without warning? And I think that it is important to point out, while these can be very severe consequences of both disorders, this loss of kidney function, it is not something that typically happens abruptly, certainly, or even in a rapid course. It is typically a more gradual problem. I think that red flags are related to blood pressure and how well it's controlled. Children who have, for a variety of kidney-related issues, who have poorly controlled blood pressure can be fatigued. They can have issues in terms of their school performance, et cetera, et cetera. So paying attention if your child is diagnosed with blood pressure, getting them the blood pressure medicine that they need, keeping their blood pressure within the parameters that you and your physicians talk about, but also monitoring your child both for side effects related to the medications and side effects suggesting that maybe their blood pressure isn't optimally well controlled. For the recessive form of polycystic kidney disease, if children have significant liver involvement, that can, again, be a progressive problem over time. The one issue that can be an acute issue is these abnormal bile ducts in the liver. Can, because of their abnormal formation, can be setups for infection. And we call that cholangitis. And that's a really severe infection that can come on rather precipitously. So again, one of the things that I tell my families of children with ARPKD is in thinking about the liver, a sudden onset of fever where a child really looks really quite ill. And you can't think about, oh, well, they have a cold or they have this, that, or the other thing. That really should prompt evaluation by your pediatrician. And the specific issue is, does your child's fever indicate that this child has this severe infection in the liver that we call cholangitis?
You've mentioned the liver involvement with ARPKD. Are there any other organ systems that are affected by the PKD gene in either type of children?
So in the recessive form of the disease, in terms of clinically significant manifestations, this disorder really has primarily two forms of manifestations: the kidney manifestations we've talked about and the liver. And the reason that I make that distinction is because the gene is expressed beyond the kidney and liver in other organ systems. But we don't at this point recognize that those other organs have clinically significant complications arising from defects in this gene. In the dominant form of polycystic kidney disease, as this audience knows, in adults, it's a systemic disorder. In children, it is primarily a kidney disorder. In adolescents, there can be the development of liver cysts, but for most adolescents, that liver involvement is not clinically a really significant problem. Now, the one caveat to all of this is that in probably the most feared consequence in ADPKD is the development of aneurysms. This tends to happen in family clusters. It's not to say that if you have no family history, this could never happen to you. But if you do have a family history, you got to be mindful of this. And we've always talked about the fact that these aneurysms, which are sort of, again, dilatations of the blood vessels in the brain, primarily, because aneurysms can occur other places, but this is where it's most concerning, that these aneurysms don't become clinically significant until adulthood. There are some case reports. So with parents who have a family history of ADPKD, and that family history is complicated by aneurysm issues like rupture and bleeding, one thing that I do point out to them in sort of the anticipatory guidance is if your child were to develop a really severe headache, that should prompt immediately medical attention, because there are some case reports of aneurysms being problematic in children who have ADPKD. Interestingly, in ARPKD, Aram Hartung here at CHOP and a couple of other investigators have reported that children with ARPKD can have aneurysms. The mechanism we don't understand terribly well. These are a few isolated case reports, but I think the same guidance applies. If you have a child with either ADPKD or ARPKD who has the sudden onset of a really severe headache, that should prompt immediate medical attention.
Yeah. I'll just again sort of turn to Marie-Pierre and ask, were there, as you were growing up, were you aware of any issues with your ARPKD affecting your liver as well as your kidneys, or yeah?
Yeah, so I was followed by hepatologists my entire life. I still am. However, like as we pointed out, my kidneys were my main issue, and post-transplant right now, my kidneys are doing well, and so now we've kind of are more focused doing the liver. I have like ultrasound very regularly to check everything, bile ducts as well. Like that's also a very common thing. But I was quite aware we would go, we would see the little nephrology clinic, and then we would walk over to the hepatology clinic and see both doctors.
Now I see that there's already a question in the Q&A, and it was something that I had planned to ask about a little bit later in today's presentation, but we might as well move to that topic at this point in time. Dr. Guay-Woodford, what are the different treatments and or ways of managing PKD in children?
So, I must say, I actually have a whole talk that addresses all these questions, I thought I wish I had actually presented this, because it's a little difficult to sort of do this in a really systematic way, answering questions. But having said that, I think that that when we think about, this was a management question, right?
Mhm.
When we think about managing these children, I think it depends on a couple of things. One is their age. The other, because I'm going to try to segue this into transitions. One is their age. One is what are their constellation of clinical problems. And then the sort of the third piece, which is not as pressing in 2024, but I think down the road is going to be more important as we think about how to manage these children, is what is the precise nature of their genetic issue. So let's take the recessive form of polycystic kidney disease. We know that, again, 2/3 of these children come to medical attention in the newborn period. Many of these children are identified before they're born. And so there is that transition from pre-birth to being an infant. That's an important transition. And there are a whole series of considerations about where those children should be born, how the care team should be organized around that birth, so that then the child transitions to a knowledgeable group of physicians for their care after birth. Similarly, for children with either ARPKD or ADPKD who are transitioning from adolescence to young adulthood, knowing what for families and now for the adolescent to really understand, yes, I have this disease, but for me, this disease means. Let me give you an example. I've taken care of these kids. It's not a very big cohort, but there are a cohort of children with ARPKD who have very, very, very minimal kidney disease, but they have really significant liver disease. So if you were to approach them with a one-size-fits-all, consideration about management in childhood, you'd be sending them to the nephrologist way too often because they don't have kidney disease. And where you really need to focus is on the liver disease. But if we're thinking about the time of transition of care, many of our kids, we start that transition process finding a partner, a counterpart in an adult healthcare system who's a nephrologist. For those kids with ARPKD, and I use the exception to make the case, for those kids with ARPKD, that's not who should be their point in the adult healthcare system. It should be the liver doctor, right? But again, with ARPKD, most children, they should have a transition plan that involves kidney doctors and liver doctors. Whereas kids with ADPKD, even those that are identified in the newborn period, those transition issues are very similar to the recessive PKD. So you can kind of think about the same sort of plan. When you get to the transition to adult healthcare programs, those children can start with an adult program. But if for the minority of kids with ADPKD, that they have a significant burden of cysts in their livers, that's a conversation that the pediatric nephrologist should have with the adult nephrologist about, we've not had to manage this in childhood, but this is an issue that will be an adult issue. And we really recommend that in accepting this patient, that you think about getting this patient also to be seen by a hepatologist. So again, the timing of where you are in this spectrum and the transition nodes are really important. The clinical issues that you have all are really important in thinking about management. And as we move down the road, I guess this is the final point, I think genetic information is going to become very helpful. So we always thought, for example, with ADPKD, there were 2 genes. If PKD1 related disease, much more severe than it is with PKD2. But now we know there are at least 8 genes involved. in ADPKD. And depending on what gene you have, there can be sort of different levels of expression of disease. So knowing the gene that's involved will be important. And even if we're just talking about PKD1, knowing the kind of defect that you have in that gene that you've inherited also may be important in helping us think about what's your likely course. Is it going to be more severe or is it going to be milder? For ARPKD, it's fascinating. Overwhelmingly, there is one gene that's involved in this disorder. And these patients, have a very variable set of, if you look over a population, very variable set of clinical courses. Some lovely work that has come from Max Lebo and his colleagues in Europe has indicated that the kidney disease, in terms of it being more severe, is related not to the kind of defect in the gene. It's where in the gene, and therefore where in the protein, that the defect occurs. And in the liver, there's a similar correlation, but the location is entirely different. So we're beginning to get a sense that genetic information can inform how we think about these patients, to a certain extent how we manage them, but perhaps even to a greater extent how we think about what their course is likely to be.
Yes, thank you. One of the question that's come in so far is, are there drugs in development like Genarc for pediatric ADPKD? And to that, I might add, is tolvaptan a possible treatment for either ADPKD or ARPKD in children? And if not, are there any other drugs available?
So we have been part of a collaborative effort to study tolvaptan or Genarc in a cohort of pediatric patients in Europe. This was the kind of study that wasn't looking for a big effect. It was looking for safety and tolerability, and to a certain extent, what the effect would be. It was not a very large study, less than 100 children. And what we found was that in that cohort of children, the drug was tolerated well and had minimal side effects, and perhaps some efficacy. And the reason this study was done was, as you know, in Canada, we know this in the United States, we know this in Europe, our regulatory agencies can add indications, pediatric indications, to a drug. The EMA determined that this study, while it showed that the drug was tolerated well in terms of safety, and people's ability to take the drug with minimal side effects, and there was this signature that suggested it might have a positive effect, that the data weren't compelling enough to prompt a pediatric indication. Physicians in Europe, physicians in North America do use this as an off-label therapy for children who have really massively enlarged kidneys. Here I'm talking about ADPKD. I think the value of this study, even though it didn't lead to a change in the labeling indications, is that in a cohort of children who were rigorously, studied, that this drug seemed to be tolerated reasonably well and safe. And so it's not, sort of with no data that a physician might think about prescribing this drug for what they consider to be an at-risk individual. I think one of the other things that is important is that again, led by Jalila Micheli in Belgium, we're doing an international study to think about the dimensions of the kidney as a risk factor for progression. So we know in adults, there's a Mayo classification that says, your size of your kidneys, depending on your age, are you at risk for rapid progression, or are you likely to have a very, much slower course? Those data are only good for patients 15 years of age and older because of the original data set from which it was drawn. And so trying to see, can we figure out in children, are there parameters that, again, can portend how a child is going to progress. And that will be important in terms of thinking maybe not just about tolvaptan, but about other drugs. In terms of ARPKD, there is an international study that is currently enrolling. It's a very small study, 20 patients worldwide, to again look at safety and tolerability of tolvaptan in children between 28 weeks and 18 years. Yes, I know that's a remarkable range. But thinking about safety and tolerability of this drug for those children. And again, there are certainly instances where this drug has been used in kids with ARPKD. I want to close because this is a Canadian audience with something kind of in between. ARPKD, typically much earlier presentation, more severe course through childhood, and ADPKD. But there have been children reported from Canada, from other parts of the world too, where they have not one, but 2 copies of an ADPKD gene, like PKD1. And they look very much like the severe form of recessive PKD, because they have 2 abnormal copies of PKD1. And in a very limited set of studies done primarily, actually the first study was done in England, using tolvaptan in those very young children seem to have a benefit. So I think we still are on the threshold of targeted therapies for these disorders. There are some studies that have suggested at least tolvaptan is well tolerated in these 2 cohorts, and at least in this small set of patients that have 2 abnormal copies of PKD1, there has been some demonstration of benefit. So let's just say the sun is breaking the horizon, the dawn is in front of us.
Very good. The same person is asking a second question. Does his child inherit his exact ADPKD gene, or could they have a variation of one of the other ADPKD genes?
So that's a very sophisticated question. And so typically the way inheritance works, with 2 copies of every gene, one you get from your mother, one you get from your father. And so every pregnancy with ADPKD has a 50% chance of being affected from that transmitting parent. The gene defect that's transmitted from the parent is the same. The context might be different. So again, because this is a Canadian audience, there have been children who have ADPKD because they got their gene from one of their parents. But then they have another abnormal. In that portfolio of 20,000 genes, they have another abnormal copy of a gene. And those 2 abnormalities can work together to make the disease more severe. I think that's sort of one point to this question. The other point is that in the kidney, you inherit one abnormal copy, but then what happens in the tubes that make up the kidney? In the cells that line those tubes, there is a second event that happens after conception. We call that a somatic mutation. So it's not in the germline, the eggs and the sperm that obviously make children, but it's after the child is conceived. At some point in the development of that child, in those cells that line the special tubes of the kidney, there's a second mutational event that picks off the other copy of the gene. So every cell in the body has the inherited version, and some cells of the body have that second version. That second hit, if you will, that second mutational event in the child may be very different than what happened in the parent. So there is this common feature. What's in the germline is the same father to son, for example. But the genetic context in the child, both in terms of the second hit involving the other copy of this gene, or in a broader perspective, because this situation has been reported from Canada, there's another defect in a gene, and the two of them kind of gang up on the kidney and make the kidney disease worse.
Right. Thank you so much. Let's do a little bit of a pivot now and talk about the transition from teen to adult care, which is part of why we invited Marie-Pierre to this roundtable discussion. One of the questions parents might have is, when should they and the care team start thinking about this transition from being a teenager to adult care, and sort of what are the things that they need to be thinking about preparing for that?
Sorry,
So
was that for me?
I think it was for you.
That was for Dr. Guay-Woodford, but then we can.
Oh, sorry. Then I thought that was for Marie-Pierre.
Okay, I can start, or you can go wherever.
No, please go ahead.
Okay, I was gonna say, in terms of like my personal experience with my pediatric care team, we started talking about it around teenage years. And they were quite good. I had an amazing doctor, and essentially what she did is every time I would come in, she would say, okay, tell me exactly what you have, tell me what it affects, tell me, what organs it affects, where are you at? We would go over my list of medication, and I would have to kind of say, this is the name of my medication, this is what it does. And I'm not quite sure if this is somewhere you can get all over Canada, but for my medication, we use blister packs, which is kind of a book, and it has the weekdays and then your medication and time you have to take them. But on the left, it has a picture of all your medication and a description of them, at least in my experience of it. And so we would go through, and it was like, okay, you have a small, let's say, red circle pill. What is that? And I would be able to point it out and then say, oh, that's iron, and it does this for me. And we had a lot of discussions. They would show me my graphs and, teach me how I can read that, understand what it means. I think it's important to kind of start, the earliest, almost the better, because you want your child to be involved and you want them to understand. And, they were my last appointment with my pediatric care. We kind of had like a quote unquote graduation. I'm using this term very loosely, but we had a celebration, and then before I transitioned over, but they told me the name of my team, the name of my doctors, my nurses. So when I was going to my first appointment at the adult care team, I kind of knew who I was meeting already, and I was kind of prepared, and, they had spoken with them, they had my files and everything. So everything was really well laid out, but I also had a lot of discussions with them beforehand to kind of understand my own perspective, my disease, what I was taking, where I was at, for a smooth transition. And I also transitioned during COVID. So like my experience might be different than others, but I was like sent on my own because my parents couldn't come and it was weird. But that also kind of, it did help them plan a little bit, I think, better and very thorough, because they knew like I would just be sent alone for this transition.
Thanks so much. Dr. Guay-Woodford, what is your perspective as the care provider on anticipating that transition?
Right. So transitioning from adolescence to young adulthood and going from a pediatric healthcare system to an adult healthcare system, actually has been the subject of a lot of work, a lot of research, and some successes and some not so successes. And this has been going on since 1982. So it's more than 40 years. There have been some wonderful examples of successes. So, for example, the Cystic Fibrosis Foundation led the charge to help as they were helping physicians think about protocols that would prolong the life of cystic fibrosis patients, so they truly did transition into adult healthcare systems. They really helped coordinate this sort of somewhat complicated handoff. And I think Marie-Pierre put it beautifully in the sense that this is a team effort, and the captain of the team really needs to be the patient, right? Because the transition process is only as good as the patient feels informed and empowered and supported. And so if you don't have conversations that again, they're not going to be a one-time conversation, so conversations over a period of time, then they're not informed. If you don't have a sense that, or if a patient doesn't have a sense that they really understand, what their various medications are for and what the issues might be, then they're not empowered. And if patients transition and, think about it, in a pediatric healthcare system, we're built for high touch, relatively low capacity, because most children are healthy. Adult healthcare systems are built for low touch, high capacity, because adults have all kinds of medical problems. So if you transition a child from the first system into the second system, and they don't have a sense that there is some support, and that support doesn't necessarily just need to be the physician or the care team. It can be social workers. It can be peer groups. And so one of the things that we're working on here at CHOP, using what's called a learning health system approach, is to hear from patients like Marie-Pierre, what were the things you were thinking about when people started talking to you about transitioning? What questions or information would it have was helpful, and what additional information could we have provided? So that's the informational component. How could we have helped you feel more empowered with this transition? The fact that there was a physical handoff. One team is taking you to another team. That's really beautiful and very powerful way to feel people be empowered. It's not like, here's a piece of paper, show up at this place, in 3 months. But I think the whole issue about empowerment and really understanding that. And then I think thinking about the fact that these are patients who aren't coming to adult healthcare providers with a new onset of a medical problem. They've had this medical problem for a very long time. And so being supported in the context of the adult healthcare system is important. So to me, those are the things that our study is working on. And I mentioned this learning health system. And again, just preparing for this discussion, I'm mindful that the learning healthcare system is something that is really a global effort. And it's really designed to take data and generate from the data, like, how can we inform patients optimally? A set of evidence that we can then bring into how we inform our practice. And there was an effort in Canada using this model for children with type 1 diabetes. And the idea of sort of using this process of data to evidence to applying it in practice, gathering more data, and kind of having a circular, iterative, ever informative sort of loop is something that for that cohort of Canadian investigators, they thought would be very useful. I think for ADPKD, that certainly could be the case. I would be very interested in Marie-Pierre's, experience about those 3 critical tenets. How well was she informed? How much did she think she was empowered? And with the transition, how did she feel she was supported?
Yeah, I can touch a bit on that if you want.
Please.
Yeah, in terms of informed, as I said, my team was great at kind of trying to really get me into the loops. I was always told, write your questions that you have before going to your appointment. So anything that might happen, you might be like, oh, can I eat this thing or whatever? Write it down, bring it to your appointment. And I did that with my pediatric care when I was a teenager. And kind of at one point, we turned to a point where instead of asking my parents questions, they kind of started asking me. And, I feel like a lot of kids will turn to their mom and be like, hey, can you jump in here for me? I don't want to talk. But they were kind of like, no, you need to start talking and asking us for questions and all that. And I think one of the things with transitioning that for me personally was tough is that I've spent my entire childhood with my one team, especially my nephrologist. You build kind of a relationship. They've known you since you were a newborn. And so you're really close with them. You can joke around. It's great. and then you transition and it's a whole new care team. And at least in my experience, you know, in the 4 years that I've been now with the adult care, I've been changed and I've been moved to 3 different teams because I had a transplant. And so it's been, that was like weird. And I was like, oh, there's so many different peoples and I'm not sticking with a doctor very long. But I still felt quite informed before going. I forgot what the 2 other points were.
So let me just sort of do a little interval summary.
Yeah,
so
of course.
Information is that starts, and the American Academy of Pediatrics recommends that this start, sometime in middle adolescence, 15, 16 years old, because most of these patients don't go to their physician lots of times, and that you supplement that with patient appropriate information so that people can really understand some of the issues. And then there are the issues of empowerment. It sounds sort of almost kind of choreographed. They turn from your parents to you, but that's really empowering when someone says, I want to know what you think, what your understanding is. That's really important. And then the final issue is the issue of support. We do a great job, again, high touch, low capacity, do a great job. We have nutritionists, we have social workers, we have psychologists, we have all kinds of people to support our patients. In most adult practices, there isn't that sort of support network. And so thinking about, so how could we build it in without trying to change the whole system? Support groups for transitioning patients could be really important. And so I guess my question to you, Marie-Pierre, would be, as you made this transition and it was clearly successful, did either your transplant team or some of your other providers help you to sort of identify a group of your peers, young adults that had had problems since childhood and were transitioning to the adult healthcare system so that you could help each other with that transitioning?
So in my case, no. In terms of like them finding people for me, I think also part of it is like there's very few people with ARPKD, and like I wouldn't imagine a lot of us are transitioning at the same time. I did have a cheat code, which was my brother. He had transitioned before me. So I did have someone that I could be like, hey, do you have you experienced this? And we have the same doctors as well, because we both are now at the same stage. He also had got his transplant. So we're able to kind of talk about it. But in terms of during the transitioning period and having other, young adults also transitioning, and a way for us to kind of talk, it wasn't really something that was there. But, when my first appointment, I had like this very nice nurse who I love, and she the appointment was much longer than it needed to be, just because it was a lot of just, okay, let's just, what's your medical history? Even though they know my medical history, it was just very much like, tell us what you know, and let's go through the whole process, ask all your questions. So there was a lot of support from the team itself.
Right.
And then it was a matter of me going back home and being like, hey, what do you think?
Well, I think, it doesn't necessarily need to be other patients with ARPKD. It's particularly in the big transplant centers, they transplant young adults, or they're receiving adolescents, people who were transplanted in adolescence into their adult healthcare system. And so one thing that we're sort of working on is having, whether you're transplanted because you had a glomerular disease or you had a cystic kidney disease or you had other things, you are a kidney transplant recipient as a young adult. And is there kind of a support network that could be helpful to you? You had yours built in with your brother, but is there a support network that it's sort of the peer-to-peer support? Because you're very fortunate to have in the adult healthcare team a nurse who was so gracious and magnanimous with I assume her time from what you said.
Mhm.
But that's not necessarily something that all adult healthcare teams have the wherewithal to provide. They may want to, but given workflows and that sort of thing. So I think it's just something to think about. And it's in our final second, it's my way of saying to this group, if you are thinking about transitioning, part of your empowerment should be to say to the adult healthcare system, have you transplanted anybody else with kidney disease that's about my age? And could you help us kind of get in touch with one another so that this is a journey I'm not doing by myself?
Wonderful. Well, as Dr. Guay-Woodford has pointed out, we are at the end of our time. I want to thank both Dr. Guay-Woodford and Marie-Pierre Schryburt for participating today and talking about both some general pediatric PKD topics and talking about the transition from being a teenager to a young adult. I know that this information is really going to help families with children with PKD, and we just really appreciate your time. I want to let the viewers know that this session has been recorded and it will be available on our YouTube channel in the coming weeks. And all registrants will receive an email once the video is available. If you have more questions that weren't answered during this 50 minutes, by all means, feel free to email us at the email address that's in the chat, and we'd be happy to continue to find answers for you. So thank you so much, Marie-Pierre and Dr. Guay-Woodford.
Thanks very much.
Thank you.
Bye-bye.
Bye.